Good evening and welcome to day 2 of Target Volume Delineation 2021 organized by the Department of Radiation Oncology, RCC JIPMER. We had an excellent session yesterday by Dr. Cecil Keinickel on Carcinoma oropharynx covering the anatomy and staging aspects. Dr. Keinickel is Additional Professor Radiation Oncology, RCC Thiruvananthapuram. He is a familiar face among the student community in the country thanks to the multiple online and offline classes he's taken over the last few years. Today, Sir will be covering the management of oropharynx carcinoma with respect to target volume delineation and other treatment factors. Before we start, I would request the participants to be muted at all times, to keep your webcams off, and to direct your queries to the chat box so that we can put them to Sir at the end of the session. Without further ado, I hand over the platform to Sir.
Thank you very much for the kind introduction and the invitation. Can you hear me? Can you hear me?
Yeah, okay. Yes, sir, you're audible.
Thank you very much. Okay, I will share my screen. Can you stop your screen? Can you see my screen? Can you see my mouse moving? Because that is very important for today's session.
Yes, sir.
Thank you. So yesterday we discussed about the approach, investigations, imaging, and the staging of carcinoma oropharynx. Today we will be discussing about the broad outline in the management as well as the contouring guidelines. So I may not be able to present all the guidelines, all the evidence for the management because it will take 30 to 45 minutes to present the evidence. So I'll be just give an outline, but my slides contain almost all the evidence for the same. So if you have any queries, then you can get back. So I will discuss that. So coming to the treatment part. Yes. So if you have an early disease, like we have discussed this case in a T2 disease, like a lesion involving the tonsil, extending into the tonsil and a tonsillar pillar or tonsillar lingual sulcus without a nodal involvement, or a lesion in the soft palate. So how you will treat this patient? So it is a stage 1 and stage 2 disease. So it's a stage 2 disease because it's a T2 and 0 disease. So will you use radiotherapy or will you do surgery? But in all the subsites, the early disease are treated either by radiotherapy or surgery, because the principle is that the treatment should be limited to single modality treatment, and you should not use multiple modality of treatment because a narrow margin followed by postoperative radiotherapy is not considered as a standard. So if you take the patient for surgery, then that should be the end of the treatment, and the patient should not receive any adjuvant program. The same way, you consider the radiotherapy. So you restrict the treatment to single modality. So how will you argue for radiotherapy versus surgery? The surgery is usually the transoral robotic surgery. We know that radiotherapy is an established approach in early oropharyngeal carcinoma. The functional outcomes are better. There is a chance for the margin to be positive. Then there is a reconstruction issue. The patient may be on a long-term Riles tube feeding, and retropharyngeal lymph nodes cannot be treated by surgery. And there is a patient, if the patient requires postoperative radiotherapy, either due to a margin close or positive, or due to any nodal involvement, then this can lead on to a impaired function. And moreover, then this will involves more than one modality, and it can deteriorate the function and quality of life. This is the concern we have when you think about radiotherapy basis surgery in early oropharyngeal carcinoma. There is a phase 3 trial which is ongoing, but there is a phase 2 trial which was published last 2019 by the Canadian group. The study was conducted in many centers in Canada and Australia, and this published in Lancet Oncology in 2019. And this phase 2 trial, 68 patients were randomized either to give radiotherapy or you give a transoral robotic surgery plus neck dissection. So this was and the patients were enrolled were up to N2, T1, T2, N1 to N2 patients were included. And the patients received radiotherapy by IMRT technique, or the patients received surgery plus bar minus adjuvant treatment if there is an indication for post-operative radiotherapy. 34 patients received radical radiotherapy, and 34 patients were randomized to the surgery. But subsequently, 10 patients received in the surgery group, 10 patients received the radiotherapy, surgery, and neck dissection alone. Means a majority of the patients received adjuvant treatment or adjuvant chemoradiation. So it means it started with an early disease, it ended like receiving surgery followed by post-op radiation. The primary endpoint of this study was quality of life based on an MD Anderson dysphagia inventory score. That was the primary endpoint. Although there was no difference in the overall survival or progression-free survival, the quality of life score was better in patients who received radiotherapy compared to patients who underwent transfer of robotic surgery plus bar minus adjuvant treatment. There is a similar trial in the HPV positive patients is undergoing phase 3 trial evaluating the similar design in comparing radiotherapy versus surgery. So we do not have, the phase 2 trial shows similar locoregional control, but the quality of life is better with radiotherapy. That is what we can understand from the evidence as of now. Now, compared to, is there any role for any systemic therapy in early disease? Because we believe that in stage 1 and stage 2, it's either radiotherapy or surgery. But in the McKenzie meta-analysis published in 2009, and showed that in stage 1 and stage 2, number of patients were less, but there was no benefit by adding a systemic chemotherapy compared to local treatment. That is the bottom line. So it is treatment is either radiotherapy or surgery. Now, the locally advanced disease, that is stage 3 and stage 4 disease. So I discussed in yesterday we discussed about the composite staging. Stage 3 is T3 or N1. That is stage 3. Stage 4A is any patient who having a T4A or N2 disease. That is all patients up to 70 years and patients who have a performance status of 0 or 1. The patient should be standard treatment is to consider for a radical approach. Any patient with a T4B, N3 disease, elderly patients, or patient with PS2 or more, then that patient should be individualized and patient should be treated with palliative. And patients with systemic disease at presentation are rare in head and neck squamous cell carcinoma. Coming to a clinical scenario, 66-year-old gentleman who is a chronic smoker and alcoholic, performance status 1, presents with carcinoma of oropharynx. Yesterday we have seen this CT scan. The lesion is involving the base of tongue and the lateral pharyngeal wall, and also just extending into the prevertebral muscle, the posterior pharyngeal wall. So this is the lesion, T2 disease, with a level 2 lymph node. So this is a level 2 lymph node. So it's a T2N1 disease. So how will you treat this patient? The options given are 1, radical radiotherapy, 2, transoral robotic surgery plus radiotherapy, concurrent chemoradiation, or transoral robotic surgery plus neck dissection. So I have to put a neck dissection here. So you can answer now. So I want a few answers, then I will take up the question. Then I will take up the clinical scenario. So how you will treat the T2N1? Will you give chemoradiation or you will give radiotherapy alone? 1, radical radiotherapy. 2, chemoradiation. Okay, everyone is for 1, radiation alone. Okay, CT. Okay. Now I know. Okay, Nazara. So you are concerned whether you will give chemoradiation or radical radiotherapy alone. There is if you look into the large retrospective analysis from MD Anderson group that published few years back have shown that the benefit of chemotherapy in patients who have oropharyngeal carcinoma up to the nodal size less than 3 centimeters, that is single node, N1 disease, that's not that significant. So if you look into the latest NCCN guidelines that is published in April 17, updated, the version third version on 2021, published online on April 17 this year, show that in T2, T1 and T2 P16 negative N0 to N1, the standard treatment is to give definitive radiotherapy. And thus, if you want to give concurrent chemoradiation, it is a category 2B recommendation for T2N1. It was category 2B recommendation. So category 2B recommendation was a definitive radiotherapy. So the radiation is good enough in patients who have T2N1 carcinoma oropharynx. Yes. Coming to the advanced disease, 62-year-old gentleman who is again a smoker and alcoholic presents with a carcinoma of the oropharynx, the left tonsil. You can see the lesion there. So here you can see a lesion in the left tonsillar fossa extending into anterior tonsillar pillar. And palatopharyngeus is also the posterior aspect, posterior tonsillar pillar is involved. So it's a T2 disease. And patient who have two nodes in the level 2 region. So this is the level 2 nodes are there. And so this is why it is a level 2 node? Because it is behind the submandibular gland. This is submandibular gland, and this is medial to the sternocleidomastoid. And this is within the posterior limit of the sternocleidomastoid. So it's a level 2 node. And this is the internal carotid artery. This is the internal jugular vein. The patient is having 2A and 2B node. Why 2A and 2B? Because 2A and 2B is divided by the posterior edge of the internal jugular vein. So this is the posterior edge of the internal jugular vein. The node which is lying anterior to this posterior edge of the internal jugular vein is 2B node. And the node behind the posterior limit of the internal jugular vein is level 2B node. So level 2B and 2B node with a T2 disease. So it's a T2N2B if it is P16 negative. And if it is P16 positive, it is a T2N1. And if it is a P16 negative, it's a stage 4. If it is P16 positive, T2N1, and it is a stage 1. That we have discussed. So for a P16 negative disease, so I will discuss the management of P16 positive later. In P16 negative disease, and will you give concurrent chemoradiation, or you will give induction chemo followed by radiotherapy? You will give chemoradiation plus immunocimab or chemoradiation plus cetuximab, or will you give induction chemo followed by chemoradiation? So which one you will give for this patient? The P16 negative, T2N2, concurrent chemoradiation, induction chemo followed by radiotherapy. I don't think anyone will answer for radiotherapy alone. So I want your answers. Yes, so it is concurrent chemoradiation. Okay, yes. So yes. Okay, you will give concurrent chemoradiation. So everyone agree that this patient will receive concurrent chemoradiation. So I don't think I need to discuss the evidence for all this, but I will give you a brief outline. You need to understand that the patients who are candidates for locally advanced head and neck squamous cell carcinoma who require plan for radiotherapy as a definitive treatment, like the advanced oropharyngeal carcinoma, advanced larynx and hypopharynx intact function and the cartilage of larynx and hypopharynx. Then selected gingivobuccal complex tumors, advanced disease. This can be treated by chemoradiation program. And all the nasopharynx is a separate disease, so I'm not going to discuss that. So the main pillar of the treatment is the main course is by radical radiotherapy. So a high quality, good quality radiotherapy that is delivered with accuracy. That is the pill that forms the pillar of the treatment, plus systemic agent. So the main dish is radiation, and this is the systemic agent. And the most important thing is that the patient should complete the radical radiotherapy in this, because the main pillar, backbone of the treatment is a high quality radiotherapy. Now, when you look into the various McKenzie meta-analysis which has published over the years from 2000, you can see that in Lancet 2000, the McKenzie meta-analysis have shown that if you incorporate a systemic therapy in addition to the locoregional treatment like radiotherapy, you can see that the concomitant was showing an 8% absolute benefit at 5 years. And the adjuvant and neoadjuvant were not showing any significant benefit. It is the p-value was not significant. The benefit was confined only for the concomitant when you give radiation and chemotherapy together. The data was updated in 2009 in Bean Journal with incorporation of large number of trials, and it included almost 93 randomized trials and included 17,000 patients. And with the trials incorporated between 1994 to 2000, the primary endpoint was overall survival, and the median follow-up was 5.6 years. And this was accompanied by a very good editorial by Jens Overgaard Jens Overgaard, then from Denmark. So this is a very good editorial. I request all the residents to read this editorial, excellent editorial. And it showed that, when concluded that the concurrent chemoradiation is superior to radiotherapy alone in terms of overall survival and locoregional control. The absolute benefit was 6.5% at 5 years. Induction chemotherapy had no benefit. The maximum benefit of chemotherapy was seen in young patients and with good performance status. The single agent is equivalent to combination chemotherapy. That is why you give single agent cisplatin along with radiotherapy. Cisplatin is better than other agents. The cisplatin hazard ratio was 0.74. So it means there was a 26% relative reduction in death in patients who received cisplatin. That was the conclusion from the paper that published in 2009. And there is a recent update that came in March in 2021, this year. And this included more than 100 randomized trials and 19,000 patients. Initially, it was 17,000 patients. Now it is 19,000 patients. The same group, the McKinsey group, and the primary endpoint was overall survival. The other endpoints were the event-free survival, local regional failure-free survival, 20-day mortality, distant failure, cancer and non-cancer mortality. The main aim of this meta-analysis, individual patient meta-analysis, was what is the role of chemotherapy in addition to local regional treatment? That is, local regional treatment versus local regional treatment plus chemotherapy. When they analyzed the concomitant part, the median follow-up was 9.2 years. The primary endpoint was overall survival. The hazard ratio of death was 0.83. It was quite statistically significant. And the absolute benefit was 6.5% at 5 years and 3.6% at 10 years. The event-free survival and the event-free survival was also better in patients who received chemotherapy in addition to radiotherapy in the concomitant fashion. And it was 5.8% at 5 years and 3.1% at 10 years. There was no increase in 120-day mortality. The local regional failure was also better in patients. The failure-free survival. Local regional failure was less in patients who received chemotherapy along with radiation, and this hazard ratio was 0.71. And there is no difference in distant failure because the concomitant chemotherapy did not reduce the distant metastasis. There was a benefit in terms of head and neck. That is, head and neck survival. There was patients who had head and neck survival. Head and neck cancer death was reduced in patients who received the chemo along with radiation in the concomitant fashion. Now, induction chemotherapy at a median follow-up of 5.7 years, the hazard ratio of death was 0.96, and this was not significant. There was no difference between the various regimes, including TPF. That is, TPF hazard ratio was 0.9, and for PF, its hazard ratio is 1. It means there is no much difference, and this was not statistically significant. So what does it mean? Even in patients who receive the induction chemotherapy basis local regional treatment, either a 2-drug or 3-drug, there is no much benefit. And the benefit was mainly seen in concomitant. And local regional failure there was a trend towards reduction in local recurrences, but there was a significant decrease in distant failure in patients who received induction chemotherapy. But when we analyze the individual patient, the various phase 3 trials, the benefit was not clearly seen. And patients who tolerated the induction chemotherapy, there was a poor tolerance in patients who had poor performance status. That was induction chemotherapy. Adjuvant chemotherapy, although there was a benefit in terms of decrease on local regional failure, also a decrease on distant failure, but this was negated by an increase in 120-day mortality. The hazard ratio was 1.89, and there was a hazard ratio of death was 1.02. The benefit of this in local regional and the distant failure, the benefit was negated by 120-day mortality. It means the patients who received adjuvant chemotherapy had a high mortality in the initial first 120 days, and the hazard ratio was 1.89. This was quite statistically significant, and it means that adjuvant chemotherapy should not be given in head and neck cancer. Now, comparing the concomitant basis, induction chemotherapy is a direct comparison was there. The indirect comparison, if you look into the direct comparison at a median follow-up of 9 years, all the parameters, overall survival, event-free survival, and local regional failure, all this favoring the concomitant compared to the induction chemotherapy. The absolute benefit for overall survival was 6.2%. The event-free survival, it was 3.7%, and local regional failure, it was 5.8%, and all were statistically significant, favoring concomitant basis induction. And there was a site-wise meta-analysis which was published in 2011 in Beam Journal. It showed that for oropharyngeal carcinoma patients who received the concomitant, the hazard ratio of death was 0.78, and the absolute benefit was 8.1% compared to the local treatment alone. And this was quite statistically significant. So that is if you look into the induction, 3-drug induction basis the concomitant, or you add an anti-EGFR in addition to concomitant chemoradiation, or you add immunotherapy, you add altered fractionation, or you give induction followed by cetuximab plus radiotherapy compared to concurrent chemoradiation, there's no benefit. All were, and the bottom line is that the standard treatment is to give concomitant chemoradiation. All the evidence for all these clinical scenarios are given in my slide. I think it has already been sent to you. If you have any queries, please let me know. I will not be able to explain the whole thing because in this session, because we need to discuss the target volume delineation as well. The conclusion from all the trials, the induction chemo followed by radiotherapy, that is from the McKenzie meta-analysis and also from trials, have shown that there is a response rate is better. There is no improvement in overall survival or local control, but various trials have shown there is a better organ preservation. And concurrent chemoradiation is the standard treatment. Induction chemo followed by chemoradiation, even pre-drug, followed by chemoradiation, no benefit. There are 3 trials are there evaluating that role, and there is a meta-analysis. There is no benefit. When you give cetuximab plus radiation, it's not suitable for that. If you look into the role of target agents along with concurrent chemoradiation, there are 3 studies evaluating that role. One with the cetuximab, other with salutamab and nimacimab. All the trials fail to show an improvement in overall survival. One trial have shown an improvement in progression-free survival and the locoregional control at an expense of improvement in grade 3 and grade 4 toxicity. The altered fractionation have shown a reasonable alternative in patients who cannot give a candidates for concurrent chemoradiation. And the Javelin study, which very recently, Javelin 100 study, which presented in the last ESMO meeting, very recently published in Lancet Oncology, have shown that addition of avelumab in addition to concurrent chemoradiation have not shown any improvement in no benefit in terms of overall survival or locoregional control, but there is a slight increase in toxicity. If you want to use an induction chemotherapy, then a 3-drug, the cisplatin 5-fluorouracil and docetaxel may be superior to the cisplatin 5-fluorouracil. But in certain situations, you may have to use an induction chemotherapy, mainly because of logistic reasons. If you have a delay in simulation or if you're planning an IMRT for this patient, and this may shrink, and you may have to do an adaptive IGRT, so you have to avoid that, then you may use induction chemotherapy. So there's a lesion in the base of tongue extending into the vallecula. You can see a lesion in the vallecula. You can see a very large node encasing the vessels as well as the infiltrating the sternocleidomastoid. So in these patients, you may require induction chemotherapy if you're planning for radical approach. Very advanced disease, patients with extensive skin involvement, extensive muscle involvement, encasement of vessels, then you may have to sort for a palliative treatment. So this has to be individualized. We need to consider certain factors before considering palliation. The age of the patient, what is the primary primary stage of the disease. Let's say whether it is a T2, T3, it's a low limb disease, then you try to give radical treatment. Patients with HPV clinical characteristics or P16 positive, patients with excellent performance status. In these patients, the small primary large node, you give chemoradiation plus bar minus salvage resection. So this has to be individualized because it's a stage 4 disease. You cannot say that all entries are treated in the same way. There are some a young patient, good performance status, small primary with an entry node. Then I will be for chemoradiation for that patient. In that situation, you may consider induction chemotherapy followed by chemoradiation due to the logistics. In patients who have a large ulcerated node on one, this may be 8-9 centimeters, large ulcerated node with a large primary, or patients around 60 years, 2 patients, generally are considered for palliation because the patients may not tolerate the treatment due to large volume, poor performance status, elderly patients, generally are considered for palliative. Now coming to the HPV positive disease, so we were discussing about it means I will take up the questions at the end. I think that will be fine. So then I will move to the HPV positive disease. HPV positive disease is a different disease entity. Yesterday we have seen that. Now for the main, yesterday I was telling all these patients have a good prognosis. The 3-year overall survival I discussed yesterday based on the paper published in New England Journal of Medicine 2010. The 3-year overall survival is 94%. So we need to reduce the toxicity. So how to reduce the toxicity because they are going to live longer. That is called the de-intensification strategy. Either it can be done by radiotherapy or by doing a surgery, by less invasive surgery. So first approach is in the radiotherapy based. They can be replaced the cisplatin with cetuximab, so along with radiation. That is number one strategy. Second, you give induction chemotherapy, then you reduce the dose. And you may avoid, you reduce the dose as well as reduce the volume. Second is you give chemoradiation, but decrease the dose of radiotherapy, and you reduce the dose of chemo as well. The other option is in patients who have AN1 disease or a small nodes, can we omit chemotherapy? Can we use protons instead of photons? So you will have a reduction in toxicity. The other approach is surgery based. Say you do surgery in those patients who do not have an adverse features, do not have an adverse features, you follow. If the patient have intermediate risk, like patients who do not have margin positivity or patient do not have multiple nodes positive, no extracapsular extension, whether these patients can be randomized to you give less dose of adjuvant from 60 to 50 gray, and can we use a less dose of radiotherapy for patients who are margin positive, extracapsular extension from 66 to 60 gray, then with a low dose chemotherapy. So these are all treatment approaches and these are all underway. So what we know as of now is that whether we can replace cetuximab with cisplatin. So this, sorry, we can be replaced the cetuximab for the cisplatin. The concern is that we cannot, because based on 3 phase 3 trials, and 2 of them are published and 1 is underway. The 2 trials, one is from the UK group and other is from the American group. The UK trial, that is by the de-escalate trial, by the de-escalate HPV trial group published in Lancet in the 1st January 2019. And the RTOG study, that is the NRG study 1016, this was presented in ASTRO annual meeting in 2018 and published in January 2019, both published in the same edition of the Lancet in the first month of 2019. And there is a slight difference between these 2 clinical trials. If you look into the de-escalate trial, the primary endpoint was toxicity, and this includes the only low-risk patients. The RTOG 1016 trial is a phase 3 trial, a large number of patients. It included low-risk and intermediate patients. The primary endpoint was an overall survival. And this was a non-inferiority trial because this was to know whether the cetuximab can replace cisplatin, so the cisplatin-induced toxicity can be reduced. That was the concern. And when we look into the results of these 2 trials, and this included, first we will take the UK trial, only low-risk patients. It showed there is no difference in between the outcome. That is the primary endpoint was toxicity. There is no outcome difference in the primary endpoint. And if you look into a median follow-up of 22 months, it was found that the 2-year overall survival and 2-year recurrence-free survival were better in patients who received cisplatin compared to cetuximab. It means even in low-risk patients at a median follow-up of 22 months, we cannot replace cetuximab with cisplatin. The conclusion is that HPV positive disease have good prognosis. There is no difference in toxicity between the 2 arms. Better overall survival and less recurrence are seen in patients who have cisplatin plus radiotherapy. So cisplatin plus radiotherapy remains standard of care even in low-risk HPV positive. Okay, now the RTOG 1016, it was a non-inferiority margin was 1.5, and this did not meet that. Although there was difference in the toxicity profile between the 2 arms. Those patients who had received cetuximab had more of the skin as well as acneiform rash, whereas in patients who received the cisplatin had more vomiting, the hematological toxicity, as expected, the hearing toxicity were more in patients who received and were in patients who received cisplatin. Compared to the mucositis, there is no difference between patients who received cisplatin. At a median follow-up of 4.5 years, the patients who received cisplatin had a better overall survival and 5-year progression-free survival compared to cetuximab. So that is from these both trials, conclusion is the overall survival and the both trials showed overall survival in patients with cisplatin compared to cetuximab. Now coming to a homework I have given yesterday. This is a 52-year-old gentleman presents with clear tonsil that is 2.5 into 2.5 centimeters and multiple nodes on one side, same side. So this was a T2 disease involving the base of tongue, tonsil, and the posterior tonsillar pillar. And this lesion, T2 disease, with two nodes. So what is the stage? I told the stage for a T16 positive is T2N1. Composite stage is stage 1. Will you give concurrent chemoradiation or you will treat only with radiation? You should give concurrent chemoradiation. Because although it is a stage 1 disease, you are not in a position to treat with de-intensify as of now. So we have to treat like a HPV positive. Like, so it's a T2, N2B, it's a stage 4. If it is a P16 negative, it's a stage 4. You will treat with concurrent. The same way, we are not in a position as of now to de-intensify even in a stage 1 like this with a positive. Those who are interested, you can go through this chapter. This is from contribution from our department. This is a chapter in the textbook, the pharynx, the diagnosis and treatment. I've given the link, okay, so you can go and download it. Okay, so these, if you have, I have discussed everything, all the aspects about human papillomavirus or oropharyngeal carcinoma from diagnosis to management. So you can go through this chapter, and you can, and if this may be, you can come it as an short note or even come as an essay for your exam. Now coming to the contouring part, two guidelines. One is the delineation of primary tumor clinical trial CTV in the oropharynx, larynx, and oral cavity. This came published in Green Journal in 2018. And for the nodal oleum delineation, it is by the selection of lymph node target volumes for definitive head and neck radiotherapy. That is in 2019 update. So I have given this too. So these are the backbone for the contouring of the guidelines. But there are some limitations in implementing these international guidelines in our clinical practice, because most of the times we may not have the MRI taken in the treatment position. Number two, most of the oropharyngeal carcinoma in the Western population are HPV positive disease because they are more well demarcated, more enhancing tumors. Here we come across more of an HPV negative disease, more diffusely infiltrating tumors, small large primary disease compared to the HPV positive disease where the primary is small. Their concern is to reduce the mortality to the primary site. And I mean, they have an excellent salvage surgery team, and we need waiting period. Sometimes the patient may deteriorate the general condition after the chemoradiation. The patient, we may not come across, there may be waiting period in our institution, and all the centers do not have experience in salvaging oropharyngeal carcinoma. So due to many factors, we have limitation in adopting that high stringent the contouring guidelines in Indian population. We need more time to adopt that because of the factors I mentioned. So I will discuss the first article, that is the acquisition of the planning CT scan. That is one of the queries which was posted yesterday to me. That is, the patient should be in supine position with a flat top with head neutral position. Earlier it was hyperextended. Now we more believe that it should be reproducible. It's a reproducible immobilization device with 4 to 5 clips, at least 5 centimeters of tissue slab beyond the target, because that's important. Acquisition of 2 mm thin CT section is preferable. 2 mm, 2 to 3 mm. That's better to have 2 mm size. We use 2 mm size. CT acquisition should be done with contrast if automated or manual, but if possible, you use automatic because that is done with, so always the patient should have a contrast. The dose is 5 ml, 1 ml per. Now we need to know that the GTV, that is the accurate delineation of the primary. The GTV forms the foundation of the control. So we should not miss anything. At the same time, we should not give excess dose to the surrounding normal. So it should be a balance between these two. So accurate delineation of the primary tumor is a key step in clinical and radiology. And we need to give the CTV, that is clinical target volume, means GTV plus a volume of the normal tissue at risk for microscopic tumor infiltration with a probability of occurrence considered relevant for that particular therapy. That is the CTV. And if you use multiple fusion techniques like CTV, MRI, and MDT PET, it can overestimate the macroscopic tumor extent, but at the same time, underestimate the microscopic tumor infiltration. You need to have a proper incorporation of the clinical findings and radiological findings for contouring the GTV. And what about the CTV? We have two PTVs, that is the CTV P1. CTV P1 means you give a margin around the GTV. That is called the CTV P1. Always it should be a 70-degree equivalent dose. Sometimes we may be using a simultaneous SIP technique. So the dose to the primary should be, that is the CTV P1. CTV P1 should be 70-degree equivalent dose. And what margin? Generally, if you look into the DEHNCA guidelines published in 2013-14, then the international guidelines is a 5 mm. GTV plus 5 mm is called the CTV P1. And you in the international guidelines, they say the adaptation for the air cavities. You can edit from the air cavities. Also, we need to understand that the complex head and neck anatomy, we need to take that also into consideration. And also, we need to understand the anatomical barriers like bone or the fascia there. So we need to understand strong anatomical barriers preventing the tumors. And also, you need to consider the surgical seniors, the data from surgical seniors. So all this together, the conclusion is that you give 5 mm margin to the GTV. That is called the CTV P1. And the international guidelines saying the editing from the air cavities and other structures that I will discuss in detail, although we have not adopted that into our daily clinical practice, to be very honest with you, because we have a lot of limitations in that. Then the international guidelines coming to this is published in the Green Journal in 2018, the paper which I mentioned. This is a T2 tones. Okay, so you have the GTV, and this is MRI. You can see the lesion just extending into the anterior-tonsillar pillar, and this is in the tonsillar fossa, not coming to the midline. So this is your GTV. Okay, we use MRI-based plan. This is your GTV. Now coming to the CTV, when you take a CTV in the axial cut, this is the red one. This is the GTV. Okay. Then you have the green one. This is your CTV P1, and you have another 5 mm that is called the CTV P2. So what we do is you take a 5 mm. Okay, 5 mm margin. Then here they have edited from the posterior pharyngeal wall. Can you make out my mouse moving? Can you?
Yes, sir, it's visible.
Yeah. So this is the green one. So if you take the CTV P2, this is the CTV P2, that is 1 centimeter from the GTV. If you take all around, then this will come to the vertebra. Okay, it is coming to the vertebra and also the prevertebral muscles. So what they have done, they have edited the CTV P1 and CTV P2 from air cavity. This is one air cavity. So the blue one is reduced to the green one. This is the CTV P1, P2. Then also the CTV P2 is edited from the prevertebral muscles and also from the medial pterygoid muscle. So this is the medial pterygoid muscle that we have seen yesterday. This is the reason why we have taken a detailed session on radiological anatomy yesterday. So it is edited from the medial pterygoid, the prevertebral muscles, and the air cavity. So this, the green one, will be the final CTV P2, and this is the CTV P1. So if we look into the sagittal view, and this is the medial pterygoid muscle, and this is edited from the medial pterygoid muscle. Okay, this is edited from the medial pterygoid muscle, then it is edited from the air cavity. And so the medial pterygoid is paired, the prevertebral muscle is paired, and the air cavity is not taken into consideration in the T2 tones. Okay, and you have a T2 base of fan. So today we are going to take a case on base of fan. That is why I'm taking the international guidelines. So this is a base of fan. This is a base of fan lesion. And this is the lingual surface of the epiglottis is free. And when you take the GTV, so when the sagittal view, this is your GTV. Okay. Then you give 5 mmR. So this is the green one in the CT scan. And you edited from the air cavity. You have edited from the air cavity, and you have edited from the prevertebral muscles also. And also in the lateral, in the sagittal, you can see that it is edited from the hyoid bone, and it is not taken into the prevertebral muscles. Okay, and also superiorly it is edited from the soft palate. It is edited from soft palate, edited from the hyoid bone, prevertebral muscles, and the air cavity. So you need not take purposefully into the prevertebral muscles for a T2 basic attack. But in a T3 disease, generally it will come because the lingual surface epiglottis is involved. This is a T3 disease. So this is the epiglottis. You have two surfaces. This is the lingual surface, and this is the lingual surface. That is what you see here in the MRI scan. So this is extending into the lingual surface of the epiglottis. Although it is a small tumor, since it is extending into lingual surface of the epiglottis, it's a T3 disease. And in that situation, they have edited from the posterior, they are edited from the air cavity and from the prevertebral muscles. But you cannot edit from the prevertebral muscles. Sorry, pre-epiglottic space. The pre-epiglottic space is involved. It is not involved, but it is taken in this T2. So the red one is your CTV, is your GTV. The green one is your CTV P1, and the green one. So this is green one is your CTV, and the blue one is actually the CTV P2, but they have edited from there in the posteriorly and also from the air. So that is your this one green. Okay, you cannot clearly see that. So that is your CTV. Now, today we are just going to discuss a case. So I will take up the concluding of this case. A 65-year-old gentleman, performance status 1, and patient present with a foreign body sensation and odonophilia of 6 months duration. Clinically, there was a lesion in the base of tongue involving both sides, and the posterior extent of the lesion was not palpable. The left tonsil was involved clinically, and the anterior tonsillar pillar and tonsil was involved. The oral tongue and the floor of mouth was normal, because that is why I told you the soft palate. Yesterday I mentioned the importance of clinical examination. Clinically, there was a left level 2 node. It was 1.5 into 1.5 centimeter on the left side. And the endoscopy showed an ulcer-proliferative growth involving the base of tongue, extending into valvula, and then also down to epiglottis and ariepiglottic. Biopsy showed squamous cell carcinoma, and it was the P16 was negative. 65-year-old gentleman, smoker, presents with a lesion in the base of tongue, extending into epiglottis and ariepiglottic fold. What is the stage of the disease? So can anyone mention the stage of the disease? Primary site? Can anyone mention about the stage of the disease? Can you type the stage of the disease? It is a T3, T4. Okay, so it is a T4 disease. It is T4A because it is extending it is a oropharynx extending into the larynx. Up to lingual surface, it is T3, but it is finally extending into ariepiglottic fold, and then it becomes a T4 disease. And the node is the level 2 node. It's a mobile node. So it is a T4A1. Combo stage is stage 4A. Okay. Now coming to the imaging of this patient. This I will show you the CT scan, and this from the I'm not showing into the areas. So yesterday I have discussed about all these muscles. This is the genioglossus muscle, the hyoglossus muscle. This is the mylohyoid muscle, and this is the sublingual space. Now you can see some enhancement is normal because of the lingual tones. So because of this, but there is an asymmetry. It may be normal. You cannot make out whether the disease is there, but it makes you suspicious. Okay, there is an enhancement area here. So that this is asymmetry is there. Okay, and also the left lateral pharyngeal wall is little more thick compared to this side. Okay, you have to suspect, and you can see a level 2. behind the supine blood gland. Okay, so this is a level 2 input because it is anterior to the internal jugular. It's a 2 input. So, okay, then we will go to the next slide. It becomes a triangulation involving the base. In between cuts I have deleted because then that will involve a lot of. So this is the base of triangulation extending entire filling and also coming to the level of vallecula. This is coming to the vallecula. You can make out the right vallecula, but you cannot make out the left vallecula. And it is involving vallecula and also coming up to the posterior pharyngeal wall. Coming to the lesion in the area epiglottic bone. This is the area epiglottic, left area epiglottic, right, left area epiglottic. This is the left pyramid. Lesion is involving the up to the pre-epiglottic space. The epiglottis is involved up to the pre-epiglottic space, area epiglottic bone. Same here. So this is the lower limb. And also coming into the crossing to the opposite side also. So this is on the right area epiglottic bone is also important. This is the G. So it is a T4 disease. MRI is not that good quality MRI. Okay, so this is a lesion in the base of tongue, lesion in the base of tongue coming on both sides, coming to the vallecula, and also involving the pre-epiglottic space, area epiglottic fold, left area epiglottic fold, epiglottic up to the pre-epiglottic space. So this is a T4 disease. So stage of this is T4. Now, before contouring this patient, you should have a proper checklist. Okay. One, you need to know whether anterior to when you are planning to contour a base of tongue lesion. Because I cannot discuss the contouring of tonsil, soft palate, everything in one session, one hour lecture. But I'm concentrating on one subside. That is when you're trying to contour for a BOT, base of tongue lesion, you should have a proper clinical examination. You should check whether anterior two-thirds of the tongue is involved. Then you need to, even for a 2D plan, because the borders will be changing, and you need to include the 1D level also, then an anterior two-thirds of the tongue, and floor of mouth is involved. You need to treat the 1D node. Otherwise, you need not treat. Tonsillolingual surface is involved. What about the tonsil, soft palate, inferior extending vallecula, like the pre-epiglottic space and supraglottic larynx, like this patient? What about the posterior pharyngeal wall, parapharyngeal space is involved, medial pterygoid muscle? Then what about the nodes? Whether it is unilateral, bilateral, because base of tongue lesions are highly likely to have bilateral nodes. So this you need to check whether it is unilateral or bilateral. Any extracapsular extensions, because it involves the you need to give a more margin when the patient is having extracapsular extension. So always you check plus bar minus before contouring any base of that patient. So now we are coming to the GTV. The GTV primary and GTV of the node. You have a node there that I have discussed. So this is the GTV, okay, on the primary side, and the GTV of this. And you have to include the entire, the lesion is crossing to the opposite side. This is your GTV. Coming up to the posterior pharyngeal wall, the GTV. Now you have the entire enhancing area. This is your GTV. So this is your green one. Okay, coming down to the level of the vallecula, you have to take the entire enhancing area. Okay, this is your GTV. Coming down, it is coming to the level of the area epiglottic fold, and this is your GTV. So this is coming up to the and you have a node, small node on the opposite side in the level 2, level 3 junction. A small node. Okay, so actually there was a discussion to include this. It's less than 1 centimeter, but since the lesion is a bulky and very small node, so I thought of giving a high dose to this node also. Okay, you can argue that, okay, sir, it is not required because it is less than 1 centimeter, but it is a bulky disease and there is a node, okay, at the junction of level 2, level 3. So I thought I will give a level, let's say. So coming, you give 5 mm, okay, to the GTV. That is your CTV. So that is your CTVP1. You give 5 mm margin. You can edit from air. Okay, at least you edit from the bone. Okay, this I have not yet done editing because this is involving the entire thing. So I have not edited from the air, but I have edited from the bone. only edited from the bone, not from anything else. It's a bulky disease, so it's your CTB1. Same. Okay, I'm not discussing going into the all cuts. So you give a 5 mm margin, so that is your CTB1. Again, in the CTBP1, this is the CTBP1. In the CTBP2, you have to include the pre-epiglottic space as well. I will come to that. So this is your CTB1. Then you have the high dose. So we are using a 66 grain 36. So this is the CTB60, or you call it as a 70 grain dose. So this is your CTB66. Okay. And node. Then you have the two nodes. This is your GTB. So then in the margin for the node as well as the primary tumor. So this is your CTB 6 to 6. Again in the lower parts. Coming to the CTB-P2, you give another 5 mm margin. You can also edit the bone. Okay, that is your CTB-P2. I have edited from the higher bone, edited from the vertebra, but I have included the pre-epiglottic space as well. So this is your CTB-P2. Now, if in the sagittal view, okay, so this is your GTB, the green one. This is your CTB-P1, and this is your CTB-P2. Okay, it is coming into the pre-epiglottic space because it is a disease which is coming down. And I have not edited from the prevertebral muscles because the lesion was almost coming to the prevertebral muscles. And air also not much in this. So that is the CTB. And this is another clinical scenario. Recently, the patient was involving the base of tongue, and also the tonsil, first tonsil pillar was also involved. And this is extending into the posterior vertebra. The main lesion was in the posterior vertebra. So this, the green one is your GTB. This is CTB-P1, CTB-P2. Then if it is coming to the bone, you can edit. You can also edit from the air based on new guidelines. I've not done that. And this is from the vertebra. They have edited the vertebra. So this is the same patient, and another part is the lower down. So one of the concerns in this patient is it is coming to whether it is coming to the oral tongue. In that situation, you need to treat the lymph nodes also. 1B node also should be taken at least to the 60. Another patient, similar patient with a base of tongue lesion. This is your the pink one. This is your GTB. The blue one is your CTB-P1. The green one is your CTB-P2. I have not discussed anything about PTB because it is institutional based. I am only discussing about GTB, CTB-P1, and CTB-P2. Okay, so I have edited from the bone here. So this is your CTB. Now the same patient, it was actually a T3 disease. So this is your GTB, and the blue one is your CTB-P1. The green one is your CTB-P2. Again, I've not edited from the posterior, the prevertebral muscles. Coming to the node, this was another query which was posted yesterday. How to take the nodes? So if a patient is having patients who have N2C, this patient had, you can see it is only N1, or you can see it is N2C because the opposite side also patient has small. Okay, so according to the N category on each side. So if you have an N1, so you need to treat level 2, 3, and 4. It is mandatory. So even if patient is having N0, so a patient is having an N0, you have to treat a 2, 3, and 4 on one side. So if that is 2, 3, and 4, you have to receive, you have to coordinate that. In patients who have posterior pharyngeal wall, then the patient should have a retropharyngeal nodes. Also should be part of the N1. So it should be controlled, even if it is N0. But 1B is involved in a patient, suppose a patient have a node at the level 2 and 1 junction, or patient who have a level to the dextrocapsular at the junction of 1B and level, or the lesion which is coming into a base of tongue lesion extending an adult, then 1B also should be treated. Then 1B, 2, 3, and 4 should be the treatment for base. Now for this patient, the patient had a bilateral level 2 nodes. So the level 2 should receive an intraepithelial scoring. That is another question which was. So I will discuss when we discuss the node. For this patient, you give the node plus 5 mm that is your CTB-N1. So when you have a node that GTB, then you give 5 mm margin, that is your CTB-N1. Then the patient had level 2. So the level 2, the whole level 2 will be included in the CTB-N2. Whether to give 60 gray or 54 gray, that is a matter of debate. Okay, I'm not comfortable in going down to 50 to 54 gray when a patient is having level 2. So I will give the entire level 2 to 60 gray. Okay, you can argue that if you go to, if someone else, some people will say that the entire level 2 need not be treated to 60 gray. Okay, it can also be treated with 50 gray. Okay, I'm fine. Okay, but I'm comfortable in treating. The patient is having level 2, the entire level 3 to 60 gray. Okay, I will not treat the level 3 to 60 gray, but level 3 will receive only 50 to 54. That is called CTB-N1. So CTB-N1 is GTB plus 5 mm margin. The involved nodal stations will be your CTB-N2. That is your intermediate score. The rest of the nodes, because in this patient we have treated the, you can say that 5A need not be treated because level 3 and 4A need not be, or need only be treated. But this patient had a very bulky disease involving from the extending even up to the extending into the oropharynx into the, so I have given 5A. You can say that, okay, it is not needed. Okay, I agree to them also. If I disagree, I also agree to disagree. Okay, yeah, so that is your, so level 3 and level 4A should be before. Okay? This 5A is optional. But for this patient, I have treated 5A, but I have not treated the 5A. So CTB-N2, so if you have a GTB here, you have a CTB-N1 here, and the entire level 2 will be your CTB-N2. In this area, outside 5 mm, whether this should receive 60 gray or 54. Okay, that you can decide. So, but you have to have a, this should receive 70 gray. 5 mm beyond the, that should receive the 70 gray. The rest you can say 54 or 60. But for me, it is 60. Okay, but I will not treat the entire, the level 3 or 260 gray, but I will treat it 54. So the same way, the level 2 should be 60. That's my personal view. Okay, and the different oncologists, even the different consultants have different views. Okay, so this is a CTB-N2. So this is a final volume of the patient. I will come to that. This is your GTB, okay, green one. Then this is your CTB-66. So you give 5 mm margin to the primary and 5 mm margin to the middle. So that is your CTB-66. This volume and this covering the 5 mm to the CTB-66 plus the level 2 region on both sides. Since the patient has taken considers N2C disease, then this will be a CTB-60 on this cut. Similar in another. Okay, that is your CTB-60. Now for this, and you have to control the critical structures based on the guidelines. Okay. For a patient who have an entry node, okay, I will take another 5 more minutes. Okay, then only I will be able to wind up. Okay, the 5 this you have an entry node. It's a large node, and you have encasing the vessels and also the stomach with an asteroid. For me, this patient, if you are planning for an radical approach, this patient should receive. I will give induction chemotherapy, or because if you are planning for an IGR, okay. As far as possible, my policy is very simple. You adopt, then you do an IGR, then you do an IGRT rather than doing an adoptive IGRT. Okay, so you will this patient, in this patient, you should give 1 centimeter mark. So you give, this is your GTB. Then in this patient, you can argue that this patient also should be 1B node because it's a junction of the level 2 and 1B, you have an extra. Number 2, whether the posterior level 2 will receive 54 gray or 60 gray. The entire level 2 and the muscle on the cut which is involved, then I will give 60. So this you give GTB, then I will give 1 centimeter margin around this, that is your CTB. Then plus 5 mm plus the entire level 2 and the muscle will be your CTB. Similar for the Dahanka group has I discussed about the international guidelines. The Dahanka group initially published in 2013, or if my memory is correct, in 2014. Then that is a 5 mm. You give concentric marks of 5 mm around the GTB and the CTB. Now they have come up with a guideline that is in 2020 by the Danish group. What the principle is very simple. This is your GTB. You give 5 mm margin, that is your CTB volume 1, that is your CTB P1. And you edit from that in two situations, one from air and also from bone. So when there is this is your CTB, that is 5 mm, that is your CTB P2, or they call it the CTB P2, edited from the bone and also from the air. Here also they have edited from the air. So you have a tumor there in the aspect, in the posterior one of the tongue, extending in the anterior to the. This is a GTB. You give 5 mm marking, that is your CTB P1 or CTB P1, edited from the bone, from the air cavity. Then you have CTB P2 or CTB B2. Then you give 5 mm. Okay, so that is the handle. Now I have not included the pictures of the contouring of critical structures because that itself is a different topic. So I have not included that. So this is the dose. This is your CTB 66. CTB 66. It has covered the 66 gray and 98%. The criteria is that the 100% of the dose should receive the 100% of the GT. So that is 100% of the dose should receive 100% of the GT. The dose, 70 gram dose. Then the 98% of the dose, that is 6 for 68, that is 68 gray. If you give 66 gray in 30 fractions, then 6 for 68 is the 98%. Should receive the 100% of the GT. 100%. And when you take the PT, the PTV should receive the 95% of the dose. The 100% to 100% OLM of PTV should receive the 95% of the prescribed dose. That is 6270, or should receive the 100% of OLM. Yes. That is applicable for the CTV 60. That is 98% should receive the CTV. CTV 60 should receive the 98%, and the PTV should receive the 95%. So this is the PTV. This is the green one is the CTV 60. It should receive 58 5880 centigrade. That is 98%. And the PTV should receive, this is the brown one, should receive the 95% of the dose. 100% of the PTV should receive 95% of the dose. That is 57. Okay, then I have another case for you. Okay, I need your response. The 62-year-old gentleman received chemoradiation for a soft palate, P16 negative disease, for a CT2N2 disease. The patient had an N2 disease. It was a CT2N2. After the patient had received concurrent chemoradiation, CT2N2 P16 negative. Then after 8 weeks, the primary is in remission and neck node is having, it was 4 into 3 centimeter. At 8 weeks, it was 2 into 2 centimeters. The primary is in remission. The primary has attained remission, and the neck node initially was 4 into 3 centimeter. Now it has become 2 into 2 centimeters. What will you do? One, which is the best immediate step for the patient? One, you do a clinical examination of 12 weeks. Means you wait for another 4 more weeks. Do a PET CT at 12 weeks. Okay, do a PET CT at 12 weeks. 3, do an FNAC now. 3, you do a CT scan to assess the operability. So clinical examination at 12 weeks, PET CT at 12 weeks, FNAC, CT scan to assess the operability. So I want the response from you. Okay, you will do an FNAC. Okay, so the one answer is FNAC. Do a clinical examination at 12 weeks. Okay, I want more. Okay, so clinical examination at 12 weeks. Okay, majority. Then it shows that we have not reached the time to evaluate. We cannot label it as a radioresidual disease at 8 weeks. So you wait for 12 weeks. You do a clinical examination. If the clinical examination shows it is in remission, Then you can do a PET-CT if you are a fan of doing a plan neck dissection. Then that is based on the UK PET trial. The clinical examination shows is the remission. The patient were randomized to do an elective planned neck dissection at 12 weeks, or patients were underwent a neck dissection only if the PET was showing an uptake. That was the UK PET trial. And it showed that with a PET scan at 9 to 13 weeks is a good tool in evaluate the neck for an N2 or N3 node application. There is no need to evaluate, and there is the FNAC is not going to solve the problem even at 12 weeks. Because FNAC is negative, it does not mean that there is no residual disease. So you give chemoradiation, evaluation at 12 weeks, primary is neck in remission, and you can have an option of doing a PET-CT for N2 or N3 disease. If there is an uptake, then you do a neck dissection. But if you have a residual disease at 12 weeks, there's no point in doing a PET-CT. You do a neck dissection. If there is a residual disease in the primary, then you have to assess whether it is operable. Salvage surgery is possible. Then you do that, plus bar minus neck dissection, if there was a, depending on the initial knowledge stage. This is a UK PET surveillance trial. That is a PET surveillance basis neck dissection in advanced head and neck cancer. I feel there are only 3 indications for PET-CT in head and neck cancer. One is workup of a carcinoma lesion. It is for metastatic workup and for prognosis. Number 2, in a metastatic neck node unknown primary workup, the endoscopy shows there is no disease. In that situation, you do a PET-CT, and the PET-CT will, if there is an uptake, that can guide you for a biopsy. The third indication is for evaluation of the neck after chemoradiation, like this. The 564 patients were randomized either to do a neck dissection or a PET surveillance based on PET scan for an N2 or N3 disease. The PET scan was done at 12 weeks, and it showed that there is no difference in the outcome, and the PET is a surrogate marker for PET can decide whether the patient can need to undergo. And I request you to read this article that came in PRO, Practical Radiation Oncology in 2017, the ASTRO guidelines for the radiation therapy for oropharyngeal squamous cell carcinoma. It's a very good article. I request all the residents to read this ASTRO guidelines. So one is ASTRO guidelines, second is the contouring guidelines from the DEHANCA group and also from the international guidelines. Thank you very much for your patient listening. I'm very happy to take your questions. I sincerely thank the organizing committee for inviting me for this lecture, and also congratulate the entire department for organizing this webinar. Thank you.
Thank you, sir. As expected, that was an excellent session on the management of oropharyngeal carcinoma, including the role and timing of chemotherapy, management in T4B or N3 disease. Here, sir has also covered the treatment de-escalation in HPV positive patients. And finally, sir has comprehensively covered the target volume delineation, including the latest guidelines and also the simulation protocols. Request to the participants now to please put forth your queries in the chat box. We can put them to sir and
okay.
get your doubts clarified.
One question is it okay to edit out the nodal CTV from the sternocleidomastoid muscle? Okay, the question is whether, first of all, we need to understand that whether the muscle is involved or not. If the muscle is not there, there is no need to include. If the muscle is not included, there is no need to include the muscle in your CTV. There's no need to include the muscle in this. You can edit that. In case of NACT is given to a patient, what should be the contour? Okay. So if a patient received NACT after the neoadjuvant chemotherapy, the primary and the node, okay, if there is no critical structures are there, then that should receive the initial pre-chemo volume to a 7-degree equivalent dose. Because the shrinkage does not mean that there is no microscopic disease or we need to give a 7-degree equivalent dose possible to the pre-chemo volume. And if there is an imaging is there, always you try to fuse the pre-chemo imaging, especially if you have an MRI, and you try to fuse and find you try to include that in your post chemo only into the so you can contour the GTV the post chemo, but the CTV P1 should be like that of a pre chemo if possible.
Thank you, sir. We have some more doubts.
Yes.
One question is, one of the participants has asked your personal experience on an N3B case treated with concurrent chemoradiation in terms of local regional control.
Okay. Okay, you mean the evidence for the local control for an N3B node or the?
No, sir, your personal experience managing an N3B.
Okay, personal experience. Okay, the N3B node is a heterogeneous disease. You should not put all the N3 in one basket. Okay, there are small patients, young patient, good performance status, small primary with an N3 node without a skin or a carotid artery encasement. This is a different game altogether. But if a patient is having a large node and ulcerated, and if it's not this minimal skin involvement, it is definitely ulcerated, or patient who have elderly patient who have a large primary, patient who cannot tolerate chemoradiation, then it may not be a worth exercise for considering them for a radical chemoradiation. But in that situation, the radiation alone may not be adequate to have a good local control for attaining remission. Okay. It has to be individualized. There is no, you cannot clearly say that this particular patient should be offered, because all N3 is, if it is P16 negative, then it is a stage 4 disease. All N3 is a stage 4, irrespective whether it is N3 or N3P, it's a stage 4 disease. We have to individualize. But if it is patient is having a P16 positive disease, generally they are not ulcerated node, but they are not infiltrating type of tumors. Even if the patient is having an N3 node, they may not have an infiltration of the sternocleidomastoid. And infiltration, extracapsular extension will not change the staging and will not change to the N3B in P16 positive disease. This is N3 and it is only a stage 3. And always you should consider them for a chemo.
Thank you, sir. Participant has asked on the concept of laterality in base of tongue tumor.
Okay. In a patient who have a base of tongue lesion, it is better to treat the contralateral nodes also. If a patient is having well lateralized base of tongue lesion, it is you should always consider treating the contralateral node. If you ask me a well lateralized lesion in the base of tongue and the patient is having only one node, a node on one side or no nodes on that side, or if it is N0, will you treat the contralateral? Okay. In base of tongue, it may be wise to treat the contralateral. You can even get down with to a 50 or 54 gray equivalent dose if their lesion is not crossing the midline. If a base of tongue lesion is crossing the midline, I will be tempted to treat the contralateral level 2 also to 60 gray rather than 54. But if not crossing the midline, and clinically as well as the image, I depend more on clinical examination rather than my fingers are better. We have to trust your fingers than your image. Okay, in that situation, so if this well defined, it is posterior 1/3 of the tongue, it's an oropharyngeal carcinoma. So if it is not crossing the midline, then ipsilateral level 2 will receive level 60 gray equivalent dose, no nodes. The contralateral will receive 54 to 54. But if it is crossing the midline, or if the patient is having ipsilateral node, then generally tempted to give the contralateral level 2 also to 60.
Thank you, sir. Participant has asked about the targets to be taken in high risk, intermediate risk, and low risk CTV in case of a T2N2C disease. It's not specified the primary.
Okay, so I will give an example. Okay, then I will try to explain that. Okay, for a primary tumor, there is no 3 volumes are there, only 2 volumes are there. In the CTV P2, whether it should go for a 60 gray equivalent or a 54 gray equivalent dose. For a P16 positive patients, people have started thinking that for a CTV P2, you need not go up to 60 gray. You can get away with 50 to 54 gray. But in our situation, it may be wise to have a 60 gray equivalent to the CTV. So for a T2 disease primary, then you will have a CTV P1, you will have a CTV. And CTV P1 will receive 60, 66 to 70 gray equivalent dose. That's 70 gray equivalent dose. The CTV P2 will receive 60 gray equivalent dose. Okay. If it is not, that is the primary. Okay. If you look into the node, okay, then the node, the ipsilateral node is having an end. I assume that the patient is having a level 2 node, which is an N3 node. Okay. So in that situation, N3 node, then I will give 1 centimeter margin. That is the CTV P1. Sorry, CTV N1, because that's the 1 centimeter margin to the node. That will be 70 gray equivalent dose. And the rest of the level 2 will receive 60 gray. Okay. But if the lesion, if the node is coming to the level of the level 2 and level 3 junction with an extracapsular extension, then the level 3 also will receive 60. And that is your CTV, that is CTV N1. And if no extension into the junction of level 2 and level 3, the level 3 will receive CTV N2, that will receive 60 gray. That is, will receive a 54 gray. That is your CTV N2. So CTV N1 will be 1 centimeter around the tumor. The CTV N2 will be the level 2, same region, that's the level 2. If extracapsular extension is coming to the level 3, that also will be included in the CTV N2. Otherwise, the level 3 will receive a CTV N3, that is a 50 or 54 gray. Okay, CTV N1 will receive 60 gray, sorry, 66 gray, that is or 70 gray equivalent dose. CTV N2 will receive 60 gray, CTV N3 will receive 54 gray. So if a patient is having a level 2 node, which is having extracapsular extension, the extracapsular extension, the CTV N1 will receive 70 gray equivalent. Rest of the level 2 will receive 60 gray. Level 3 and level 3 will receive, and level 3 and level 4 receive 54. Do you think that's clear to you, or you want me to explain more?
Yes, that was clear. Sir, in the case of an N3V disease with extranodal extension into the muscle, would you include the entire muscle in CTV2?
Entire muscle. Okay, the entire muscle means the sternocleidomastoid is there in level 3 and level 4. Okay, so in that particular cut, I will include the because most of the time, if the infiltration is there, when I give 1 centimeter margin, the whole of the muscle will be there in the CTV N1. Okay, but if you want to spare, will you spare a part? Okay, I may spare. But if I feel that the rest can be given the CTV N2, that is a 60 gray volume. Because if you have, I will go back. If you have the picture which I have shown, the entire cut will not receive 66 gray. You give 1 centimeter margin, and if anything is there in the posterior aspect, level 2, then that area can be treated with an intermediate scolet. You need not go to the 66 gray. Means the entire level 2. But whether the muscle is involved, the entire muscle will be involved. Most of the time, the 1 centimeter will cover the entire sternocleidomastoid. If not, when you give another 5 mm, that will be included in the CTVN.
Thank you, sir. Sir, any comments on weekly versus 3 weekly concurrent chemo?
Okay, if you look into the weekly versus 3 weekly, in all the majority of the phase 3 trials in Western population, it is given high dose cisplatin once in 3 weeks. There is no phase 3 trial evaluating in the definitive setting. There is a trial in the adjuvant setting comparing 100 versus 30 milligram per meter square by the TMH group. Although they included definitive and adjuvant treatment, but the number of patients were more for the adjuvant treatment. So I consider as an adjuvant setting. The definitive setting, we have done a phase 2B trial and we published the data, which show that 100 versus 40 milligram per meter square, there is no difference in the outcomes, but the vomiting was slightly, the grade 2 vomiting was slightly higher in patients who received weekly 40 milligram per meter square. We are not a hardcore fan of weekly cisplatin. We believe the high dose cisplatin to be the standard. We find it very difficult to find a bed for giving high dose cisplatin. That too, we give in night. In the night, there is a dedicated daycare chemo working, night chemo working, not daycare chemo. There is a ward dedicated for giving cisplatin in the night. So we find it very difficult even to find a slot for. So we give once in 3 weeks. We are not a fan of giving weekly cisplatin.
Thank you, sir. In a node positive disease, if the margin covers the vessel partially, would you be including the entire vessel in the 66 gray volume?
That's a very difficult question. Okay. To be very honest, I've also asked the question many times. I do not have an answer with you. I'm very sharing. I'm sharing my. So there is we in that situation we have to individualize the patient. Okay. Most of the time, we try to spare something, at least part of the vessel, but it may not be possible always. But purposely, I will not spare the vessel because I will treat. If the 5 mm or 1 centimeter, the patient is having extracapsular extension, if 1 centimeter comes into the vessel, I will not purposefully avoid the vessel. But as far as possible, I will try to avoid the vessel. But most of the time, it may not be possible. It may not be possible always.
Thank you, sir. Would you personally prefer SIB or phase treatment?
No, we do not go for a phase treatment. We go by single phase treatment. Okay, we use this, we define the volumes. We go by the one phase treatment. No, we because we find it very difficult. We always try to avoid an adaptive or a second phase planning. Always go by a single.
Thank you, sir. Any role of adaptive radiotherapy in carcinoma oropharynx? If at all, when will you resimulate and replan, and what would be the target volumes in such a case?
That is the worst thing that is the worst thing I want to avoid. Okay, because that's a nightmare. My senior resident or fellow has to be there, and he has to do the whole thing in one evening. We have to plan. We have to catch all the phases to replan it, and we should not have interruptions in between. So it's a very hectic business. As far as possible, we try to avoid that. Okay, but there are certain situations where there is a huge weight loss, then we will be forced to do that. So we cannot say that at what time we will do that, because whenever you feel that there is there is a difference in there is a shift, then there will be a call from the machine. Then we go for that. We will go for a con-beam CT. Then if we cannot do and adjust that, then we have to do a racing. Then racing, then we try to give you look into the initial dose received to the critical structures. Then what are the dose we are going to receive in the subsequent rest of the plan? We have to individualize. You go to each critical structures. The node might have shrunken, then the spinal cord, what dose spinal cord has received from the initial plan, how many fractions. Then you have to calculate that. Then you have to go to the tolerance to each critical structures. At the same time, we have to match the dose we want to deliver to the target volume also. So you have to individualize. Yes.
Thank you, sir. In case of a bulky N3B node with high tumor volume, how would you decide between palliation or upfront neoadjuvant chemotherapy? Are age and performance status the only indicators, or would you look at something else also?
Yeah, it's an individualized discussion, individualized decision, and it needs a lot of discussion also. Because what I'm saying is, you may be able to give a good IGR, but that may not work for the patient. So two important things: one, the decision making; number two, the execution of the decision. So if you are not taking the wise decision, then you may burn your fingers, and it will increase a lot of morbidity, and the patient may not attain clinical remission. So it may be a futile exercise, both for the physician as well as for the family. So it involves a lot of hectic work. You have to properly take the patient for a radical approach in a patient with an NPV. So what about the age of the patient? What about the performance status, family support? What about the primary stage, that is T2? If it's a patient is having a T4A, a patient with a large bulky primary, with an N3B, a patient who is borderline 65 plus, you feel that this patient, I will think in that way. Where if a patient receives chemo radiation, number one, if the patient will tolerate that, and that is number one. Number two, if the patient is having residual disease, whether the patient will have enough reserve to undergo the salvage surgery. Second, whether the patient will become a candidate for surgery, because whether it will become technically operable in that particular site, like say soft palate, it may not be possible. Okay, so you need to decide its primary site, the age of the patient, performance status, family support, what is their expectation, then whether the patient will have enough reserve to undergo salvage surgery after your chemo radiation. And even if the patient attained complete clinical remission, there is a high chance for a relapse, early relapse. So all this need to be discussed with the family. And it is not a one-way communication. It needs a lot of dialogue. So you will put the pros and cons to the patient. Let them choose. Always involve. Up to 70 years and patient who have performance sets up to stage 4 disease, you are the king. You can dictate terms with the patient. You have to undergo this treatment. But if a patient is between, say, 70 and 75, always you should listen to them. And above 75 years, they should push us to the corner and give me the radical. Otherwise, no. It is applicable. So you have to negotiate with the patient. So what about the morbidity of the treatment, expected survival, chance for more relapse, the salvage options at that time. All this need to be discussed rather than just saying that, okay, I will give chemotherapy, after 2 cycles we'll see and we will decide. No, the decision should be taken up front before giving any treatment.
Thank you, sir. Sir, any comment on photons in carcinoma oropharynx and any comparative data between IMPT and IMRT?
Okay, in a P16 positive patients, there is a phase 2 trial is underway by the MD Anderson group. Is comparing whether the proton is superior to photon in P16 positive oropharynx. To best of my knowledge, the data has not been presented or published. So we do not have any hardcore randomized data to say that proton is superior to photon as of now. But there are a lot of data saying that the proton is superior to photon in low head and neck cancer. In P16 positive, there is a specific trial is underway to evaluate.
Thank you, sir. Do you practice PTV cropping from the skin, and if so, how much of PTV do you crop?
That is okay, because it needs discussion with the pathologist. Sorry, physicist. Okay. Definitely, we in situations like say 2 mm. Okay, but in a patient with a extracapsular extension is present or not, generally we do not. Okay, so you have to take case by case in a PTV editing. That is applicable for all the other OIRs. Generally, the PTV should not be edited. That should be the standard approach. But in certain situations, we need to. Okay.
Thank you, sir. There is a confusion regarding the margin which should be given to a gross node to be included in 66 gray volume, whether it is 5 millimeter or 1 centimeter.
If it is no extracapsular extension, the CTV N1 is GTV node plus 5 mm. Okay, if extracapsular extension is there, then the CTV N1 is GTV plus 1 cm.
Thank you, sir. One participant has put forward a scenario: a 75-year-old ECOG performance status 2 non-metastatic locally advanced.
Wait. Okay, wait. I will try to read that. Okay, can you read it for me, because I'm not able.
Yeah. So 75-year-old ECOG performance status 2 non-metastatic locally advanced. There is no mention of primary site. Would you consider radical or palliative treatment?
Okay, the guy is the grandpa should push me to the corner. Okay, then see you give me a radical approach. Otherwise, it is usually palliation. Okay, but there are certain situations you cannot say all the 75 are not the same. So if a patient is having a small oleum disease, a small primary like T2N1, you feel that this patient can tolerate a radical IGRT, definitely that patient should be treated with the radical. But in other situations, if a patient is having N2B, N2C, N3 disease, or a large primary like T3 disease, like ideally it needs chemoradiation, then a patient is having a performance status 2. I'm not keen for giving radical radiotherapy alone. Then you have to discuss with the patient, okay, and the family support. Again, it is not a one-word answer. You have to discuss and negotiate with the family. Then you come out with some solution.
Thank you, sir. Is it necessary to include every subsite of oropharynx in intermediate and low risk CTV
Okay,
volume?
that's a very good question. Earlier, the concept was that if a patient is having, say, oropharynx, then at least you have to take up to the pterygoid plates, because to include the levator velae palatae muscle and tensor velae palatae muscle, which we discussed yesterday. But the concept is slowly fading away. And the concept is 5 mm, 5 mm is good enough for CTV-P1 and CTV-P2. And there is no need to include the all subset of oropharyngeal carcinoma. That is applicable for the larynx and hypopharynx as well. And that concept still holds good for nasopharynx because of the multiple sites can occur. So that is the only site where, as of now, you cannot say that the entire areas need to be treated. Apart from nasopharynx, the oropharynx, larynx, and hypopharynx. Suppose if you have a laryngeal tumor, supraglottis, the entire glottis need not be treated into the rivers or lower story. So there is no need concept of a CTV-P3 in the primary side, either CTV-P1 and CTV-P2. 5 mm, 5 mm distance. So you give 1 centimeter around the GTV, and that becomes, and if you give 60 gray equivalent dose to the CTV-P2, that's good enough.
Thank you, sir. Sir, any comment on re-irradiation, volumes in re-irradiation?
In oropharynx? Okay, that's a big topic. Okay, we can have the, please give them, because that's an individualized approach. Okay, that it needs a lot of discussion. If a patient, what was the initial dose received, and what is the disease-free interval, what is the volume of the time of relapse, then what are the critical structures close to that, whether the patient is amenable for surgery at that time, what is the performance status, if the patient can, what are the critical structures close to that, and this all needs a lot of discussion, and then you decide it.
Thank you, sir. Sir, your opinion on hypofractionation in oropharynx?
Hypofractionation in oropharynx, you mean very small disease, which whether it can be treated by a high dose perfraction? Because it involves a large volume. So high dose perfraction, if you have a small buccal mucosa or a T1 vocal cord, definitely you can go for a high dose perfraction. But in patients who have a large volume and neck also need to be treated, I don't think hyperfractionation is a good option for treating the large oropharyngeal carcinoma.
Thank you, sir. So next question is on if you are giving a 5 millimeter margin to your GTV to draw the CTV, would you confidently do it on your simulation CT image, or would you need additional imaging, like probably an MRI or?
Okay, always you, or if possible, because there was a study by the MSKCC group that published in a Red Journal in 2015. It have shown that the addition of MRI or PET in addition to CT have shown an improvement in the volumes. And the other, if you compare the MRI basis PET CT, there was no difference. That was the p-value is 0.39. So that was the conclusion from the paper. So if you can add an MRI, then that will be very good to have, especially in patients. We come across usually the P16 negative diffusely infiltrating tumors. So you can have the soft tissue expression can be better delineated by an MRI. If possible, then it's better to do that.
Thank you, sir. Sir, any comments on hyperthermia with RT?
Okay, hyperthermia RT, I leave that question.
Okay, sir. Sir, you mentioned that you do not practice de-escalation in HPV positive patients. Is there any scenario where you would consider it? Participant has asked, put forward a scenario of HPV positive young non-smoker. Would you consider?
No, as of now, we are not in a position to de-escalate, either in the terms of replacing cisplatin with a cetuximab or reducing dose of radiotherapy as of now. We do not have any phase 3 data. Okay, there are phase 2 data showing that if you give induction chemotherapy, you can reduce the dose of radiotherapy, you can reduce the volume. But as of now, we do not have any data in phase 3 manner. So we are not in a position to change the practice as of now. We need to give like a HPV positive and HPV negative disease should be treated in the same manner.
Thank you, sir. I think this is the last query. This is from yesterday's question.
Yeah.
Which MRI sequence would you use for?
Okay. Yeah. So if possible, you can use a T1 and T2. I didn't mention that. I wanted to use that. The T1 contrast and a T2 that you can use.
Thank you, sir. I think that's the end of the. Okay, we have one more question.
There was one question on, sir, the CTV should receive 98% and the PTV should receive 95% of the prescribed dose. Okay, if you are prescribing, say, 66 gray in 30 fractions, the GTV should receive that 66 gray in that 66 gray. The 98% of the dose should receive the 100% of your CTV. And the 95% of the dose should receive the 100% of.
So there's one more question.
Yes.
Whether in-field recurrences are more common in IMRT versus 3D CRT or 2D?
Okay. If you look into the 2D, the passport trial, there is no difference in the locoregional control. Okay, there is no difference. You cannot say that the IMRT, if you give IMRT, if you do an IMRT, there is a decrease in locoregional control. You cannot say so. But the problem is that if you are not properly contouring, and if you are missing a GT, a part of that, or a submucosal spread, or if you are not properly contouring the node, a node is missed, or the primary is not properly contoured, there can be geography. Then that will lead on to a poor location.
Thank you, sir. There is one last question. Any dose constraints for DARS?
Okay, I'm not taking that because we have not taken anything regarding the critical structures. The OIRs we have not discussed. So I am not planning to take that question because if we are discussing the superior constrictor, middle constrictor, inferior constrictor, everything, then you can answer that question. But it needs a lot of discussion. So it's almost 8:37. So I have to explain the whole thing. So it will take more time. So please, you can WhatsApp me. I will be happy to answer that. Okay. It's because we have not discussed that the OIRs at all. That is why I'm saying, because we have taken only the contouring of the primary and the node.
Thank you so much, sir. I think we can wind up the session of.
Yeah. Thank you so much. I sincerely appreciate for staying back till this 8:38. Okay. I also thank the organizers for the invitation. We will have a long association. Thank you once again.
Thank you, sir. We'll